Hey everybody, welcome to another episode of Very Not Random. Today, myself and Adrian get to catch up with Dr. Carolynn Francavilla. She is a board-certified family medicine doctor. She's a diplomat of the American Board of Obesity Medicine. She owns and operates Green Mountain Partners for Health in Colorado Weight Care in Denver, Colorado. She is a nationally recognized obesity expert. She lectures to clinicians on the topic of obesity, as well as teaching through her own platform, which is helpyourpatientsloseweight.com. She hosts the Dr. Francavilla Show, a podcast about health and weight. She is a founder of GLP Strong Fitness, and she serves on the Obesity Medicine Association Board of Trustees. She's also a CrossFit Level 2 trainer. So we talk about all things obesity, weight loss, pharmaceutical intervention, the whole 9 yards. Hopefully you learn something and really enjoy the program. As I always say, if you want to help support the show, go to verynotRandom.com. Check out all the different cycles that we offer. We've got on-ramp programs for getting you back into fitness for barbell, dumbbell, and a bodyweight on-ramp program. There's running programs. There's just barbell cycling and strength programs. And then there's a whole bunch of get your first fill in the blank. First strict pull-up. Kipping pull-up, first kipping bar muscle-up, first strict handstand push-up, ring dip, you name it, you got it. And then of course, if you're a gym owner, go to btwb.com, check out their all-in-one solution. You've got workout tracking, gym management, and billing, all on one platform that's the best in class. So if you're a gym owner, check that out. And other than that, enjoy today's show. All right, Doc, I appreciate you being here so we can chat about all things health, wellness, obesity, GLP-1s, the whole 9 yards.
Yeah, thanks for having me. I could talk about this stuff all day, and I do. So thank you for having me, and I'd love to share with your audience all about it.
Very cool. Well, there's a lot out there, as I'm sure that you know, and depending upon what news source or what YouTube video, whatever you click on, you might get one story or another. So maybe we just start with, what these days is defined as obesity, and why, in your opinion, has it skyrocketed to such a problem, not only abroad, but let's just say in the US right now?
That's a great question. And I suspect that over time, we're going to change what that definition of obesity is. Historically, in the US and medically, we have used BMI as the way to sort of diagnose obesity. And BMI is a screening tool. Certainly, if someone has, the higher someone's BMI is, the more likely they have obesity. But, especially with like weightlifters, you could have a BMI of 32 and have a really low body fat percentage and not have obesity. So BMI is imperfect. I'm very involved.
I have like a risk factor if you just go off my BMI, because I'm 5'8", 180.
Yeah, I bet, right? Because, it's like that's overweight or something, right? Based on the height to weight ratio. But, yours is all muscle, right? So that's
Darn
where it's
right.
a screening tool, right? It's mostly muscle. It's a screening tool when we're using that BMI to sort of say, look, is this person at risk? If your BMI is 20, you probably do not have obesity, right? But, so I'm on the Obesity Medicine Association's Board of Trustees. So we're sort of like the clinical leaders in obesity medicine. And we have a definition of obesity that's very long and scientific, but it basically says obesity is a disease when your body fat is causing problems. And so I kind of like to think of it that way, because for some people, I'll have these little, 60-year-old women who come in and they have no muscle. Their legs are like toothpicks and all their weight is around their belly. Their blood work looks terrible. They have high cholesterol, pre-diabetes, and their body fat percentage is high, even though their BMI may not be that high. It's like 25 or 26, probably less than your BMI. They have obesity. Their body fat is causing a problem. It's contributing to the high cholesterol. It's contributing to the high blood sugar. So really, I think a better way to think of obesity is when body fat, when adipose tissue is causing you a problem.
Interesting. So almost this little old lady you're talking about, she may not be walking in at 400 pounds.
No, absolutely not. She may weigh about my weight.
Yeah, it's interesting to conceive of it that way. I do like that as a framework. Now, would you extend that to orthopedic issues as well, or is that strictly related to other like
Exactly.
metabolic
So it
problems?
may be a problem with knee pain. It may be that you can't comfortably fit on an airplane, right? Maybe your blood work actually looks okay, but you feel short of breath and tired all the time, and you can't comfortably do things in your life. I have one patient who came to see me because he could no longer wipe when he was on the toilet. And that was
Mm.
his sign that, like, whoa, my weight is a problem. So that's what I try to tease out when I see my patients is your weight causing you a problem? And or is it likely to cause a problem? Sometimes for my younger patients, if we look at their family history and we see, everyone has type 2 diabetes or there's a lot of cancer, then I might be more concerned about their weight. So, again, I think in the US, standard is still BMI, but we're really trying to move more towards these definitions of how is that weight impacting your health, or how is it likely to impact your health in the future to determine if it's really obesity, which is problematic weight.
And maybe it's not your exact area of expertise. Like, you're on the treatment side of the house, not the how did we get here side of the house. I'm guessing, but from your experience, and this is just anecdotal, but you see old photographs of the beach in 1950 or a baseball game where the stands are packed in 1950 compared to 2025, and the difference is remarkable in just the size of the average American. Do you have a sense as to what is causing so many people to have to walk into your clinic to get help in this area?
I think that there's a few things, and I think most of them are not surprises. We're mostly less active, right? We have machines that do everything. Like, I don't even vacuum my own floors. I have a robot that does that. I have a dishwasher. Like, my job is sitting, talking to people all day. So most of us move less on an average
Hmm.
day than we did 50 or 100 years ago. We all drive everywhere, so we move less. Everyone knows that, right? Um, Ultra processed food in particular, it has been made so that it's more palatable, meaning we like the way it tastes more. It's formulated so we eat
It's
more of it,
delicious.
buy more of it. And so we eat more of it. And then I think the sort of third thing that gets a little less attention is other things in our environment that probably are disrupting our metabolic system. So things that people will call like endocrine disruptors. And this got a little more attention early in January of 2024. There was an article published in Nature, which is like, like the big scientific journal, right? Where they talked about obesogens, which are different things in the environment that are disrupting our metabolic system. So these may be things like pesticides, dyes, plastics. And I am a little more on the side that I think that those things have contributed. I don't think it's just the food. I think it's some of the things that have come with the food that have really disrupted our bodies as well. But that's a little bit more on, I guess, cutting edge or fringe thinking. I think that's like a
Yeah.
little less widely accepted.
Well, so if we have those three factors that you just talked about, less movement, hyperpalatability of foods, and then these other disruptors in the environment, if we look at the average person and the pie slice that kind of contributes to a problematic system, is that relatively static across most people? Or do you think it's, for some people, they're really environmentally sensitive and that should be a primary focus? For other people, it's they just have a hard time saying no to that hyperpalatability? Or, is the human animal kind of static and for the most part,
I
that pie
love
slice
that
is the same?
question. And it's definitely very different from person to person. And so when someone works with me, I do a really thorough history and I try to figure out what thing is most likely to be contributing. So there's some universal things that affect all of us, and I'll make sure I cover that. But like what is their story? Did they take a lot of antibiotics? Did that seem to be when they started to struggle? Is it genetics? Is it clearly, their family? Some people are really sensitive to not moving. A lot of my patients will have been active in their life and then they have an injury or a job or children and or all those things. And they really gain weight when they stop moving.
Hmm.
Some people are more resistant to those processed foods, don't even like them. And so it's easy to avoid. So definitely, just like I'm sure you see in athletics, right? People's bodies are just so different. And that's what makes this field interesting to me, is trying to get to that underlying reason of why someone struggles with their weight, which is very different from person to person.
Yeah.
So you said you've been treating obesity as a specialist for about 13 years now. And one of the things, before, as we were getting this interview ready, and you sent me some interesting information about how you do business, lessons learned, things of that nature. You said that there are 5 components that you focus on when treating obesity. And I wonder if we could walk through them and just you could give us a little short kind of Reader's Digest version of the high points of each one. And the 5 were identifying underlying causes. Number 2 is nutrition. Number 3, exercise, then medication, and then behavior change. And so if we just step through those, what do you mean and maybe you've already touched on this a bit, but what's your elevator pitch for identifying underlying causes?
Yeah. So that's, all the things that we've touched on, which is why is someone struggling? So the key reason, and I think if I were to be really clear on one thing on this podcast or anywhere I go, why most people struggle with weight loss is our bodies want to hold on to weight. This makes sense evolutionarily, right? We are designed to store energy in case there's a famine, right? In case there's a time where we don't have food. So it's normal to gain weight. We should be gaining weight. And most people will gain a little bit of weight throughout their lifetime. Even if they're doing all the best things, moving, eating healthy, right? So it's normal to gain a little bit of weight. And our body, even though we like to compare it to a machine a lot, is not a machine at all. It self-adjusts, it self-corrects, it's trying to reach homeostasis, right? It's trying to reach this balance. And so when we gain weight, it's really hard to lose it because our body wants to keep it on. It has been evolved to say, hey, if I'm losing weight, this is a bad thing. I need to keep it on. So when you go to lose weight, your metabolic rate starts decreasing when you've lost weight. Some people are more sensitive to this than the other. So like the study a lot of people look at is from the Biggest Loser contestants. Mm-hmm. And it showed that 5 years after being on the show, they were burning 500 calories less per day than they should be. Now, this was an average. There were some people in that study who that didn't happen to, right? But on average, but then obviously if it's an average, some people were burning even less than that a day. Yeah. So your metabolic rate goes down when you diet, when you lose weight. The second thing that happens is when you diet.
Hold on, can we back up a second? So if we are talking the average there, I guess what percentage of people saw the increase versus the decrease?
That's pushing my remembering the data a bit, but the majority of people definitely had that decrease in metabolic rate. What I recall is it was about 80% of the people, the majority. And it wasn't that many people because it was the Biggest Loser, right? It wasn't thousands of people.
I just wanted to make sure that it wasn't, 1 or 2 outliers that had such a catastrophic crash in metabolic rate.
It's definitely the majority. And there's other data that's like, bigger groups of people. And there's mouse studies as well that show, when you're in this calorie restricted state, when you lose weight, your metabolic rate goes down disproportionate, right? Obviously, smaller people burn less calories, but it's disproportionate to the amount of weight you lost. You're burning less calories than you should. So that's something that happens.
And not to delay us, and I know we got 5 days to get through, but now I'm just curious. So you mentioned that homeostasis a second ago. So if these people who lost weight, the body doesn't want to do it, and now years later, they're burning less, does that mean that the body doesn't want to establish a new homeostasis?
Yeah, it can take a while, and it's going to be variable, like you pointed out earlier, right? It's going to be variable from person to person. The more metabolically disrupted you are, the less likely it is you recover. So if we think about type 2 diabetes as having like a sign of like a lot of metabolic disruption, those people are less likely to ever get back to a normal metabolic rate. Gotcha. Someone who's younger, healthier going in may be a little better at getting back to the healthy metabolic rate. So where you're starting from seems to matter with that.
So I do want to hang here for a little bit because I know Pat and I are always tangential in the way that we approach topics. So you'll have to bear with us a little bit here, but I think this is really worth digging in. My wife and I talk about this all the time, how people talk about age and certain things that happen with age. And my wife pushes back a lot on that. And her theory is that time and dysfunction is way more important to the outcome of something, especially negative outcome, than actual age or whatever. So if we're talking about somebody who, like you said, is like metabolically, they're in a very bad place, how much impact does that time and dysfunction have? Because it sounds like from what you're saying, it's like, man, that makes it even more difficult to recover and to reestablish a new baseline.
I don't know that I have a ton of data to support what you're saying.
Sure.
Other than we do know people with type 2 diabetes are, they struggle to recover that metabolic rate more.
Yeah.
But I would agree with your thinking from what I've seen clinically for years, right? That the longer you're in that state of dysfunction, the harder it is to reverse it. Absolutely.
Yeah.
So, and again, I think of type 2 diabetes as sort of like the end stage of all this when things have really gotten advanced. And we know it's a lot harder for those people to lose weight once they have type 2 diabetes.
So then I guess the second question I have about that, and we'll probably get into that when we start talking more deeply about, next steps for people, but is it safe to assume broadly that if you have that more extreme metabolic dysfunction, the intervention also has to be more extreme?
Usually, yeah.
Okay.
Yeah,
I would agree with that. Yeah.
And that makes sense to me, right? Even with my, miserable degree in sociology, that it's probably easier to recover from being 20 pounds overweight for 1 year than 100 pounds overweight for 7 years. Like that makes perfect sense to me from just a simplistic state of mind. The second point in the 5 components when treating obesity is nutrition.
We have a few other things.
Continue.
Okay, so the one is your metabolic rate goes down. But then the second thing that happens universally is that your appetite changes. And so when you start to diet, when you start to lose weight, your hunger goes up, you're hungrier, and your satiety, your fullness goes down. And that's why it's so hard for most people once they have obesity to lose significant weight with lifestyle alone, with diet and exercise. Their metabolic rate goes down and then they're hungrier and they feel like a failure. They feel like they can't do it anymore, but it's all physiology. Their body is really trying to get them to regain that weight. So thanks for letting me belabor that point. But I do think that that's really, really key to understanding, because the way to prevent obesity is to move and eat a healthy sort of whole food diet as much as you can, right? That is how we prevent it. But when we treat obesity, that is usually not enough because of that metabolic disturbance and the fact that your body wants to regain weight. And that's why we often have to do additional tools like medication or surgery for people who really are struggling.
Okay, fascinating. It's interesting to hear you say that stuff. And now move on to the second one, nutrition.
Okay.
Do you... is there one thing you generally recommend? Is there a wide divergence? How do you address nutrition? Because man, if there's a prickly topic out there that people get like embedded in their camp and their camp's right and every other camp's wrong, this is one of them. So let's talk nutrition.
Agreed. I mean, there's nutrition zealots for everything, right? You have the plant-based people on one side, you have the keto people. I have seen my patients be successful with both of those strategies. I used to use ketogenic diets when I had less powerful tools. I think they can be great. They're hard for people to stick with forever, but they work. Plant-based diets, I find challenging for many of my patients because it's hard to get enough protein in. It's easy to eat processed foods, easy to eat simple carbohydrates. But at the end of the day, I really customize nutrition advice for the person in front of me. And that's really key, right? We have to meet people where they're at. I rarely see people come in drinking lots of soda, especially in where I'm at now. But like, I don't really care what else you're eating if you're drinking like 2 liters of soda a day, right?
Sure,
like we're going to address that first. But I also see lots of people, because I'm in Denver, people are very focused on health. There is a lot of culture around eating healthy and moving in this area that come in and they're already eating pretty healthy, right? And so, tweaking that a whole ton may not make a massive difference, if they're already doing the right things. So I think nutrition has to be what makes sense for the person. And we have data to support this as well. If people can stick to a diet, they are more likely to lose weight. And if they lose weight, they're more likely to get health improvements. So a lot of it is figuring out what culturally makes sense, what makes sense lifestyle. But the foundation is protein every time you eat and trying to eat as many whole foods as possible, avoiding the ultra processed foods. You probably can't eat too many veggies. So, those are some of the foundational things that I'm talking about with most of my patients.
Yeah, it's really interesting that it almost doesn't, well, it's not that it doesn't matter, but that there's such similar outcomes regardless of the dietary strategy. And I wonder if it just has to do with the visibility and the accountability that something like that provides being like a really key point, at least at the outset, you know what I mean? Really makes me just kind of curious around what that mechanism is.
Yeah, I mean, the better you stick to a diet, the better it works, right?
Sure.
The problem is that so many diets, whatever it is, are not sustainable for
Right.
people. And so my nutrition advice has gotten simpler and simpler the longer I've done this, really focused on, get protein so you feel full and you can maintain your lean muscle, get as much, fiber as you can through veggies, maybe a little bit of fruit, whole grains, and don't overthink it.
Yeah.
That's, I mean, simple works quite often. That's what we've found. And number 3, exercise.
Yeah. So exercise is what got me into all of this. I have always enjoyed exercising and I see the health benefits for patients. But it doesn't solve all the problems, right? So then I had to use all these other tools, but exercise is, the secret sauce to living longer and living better. All the data we have about exercise says the more you move, no matter what your weight is, right? You're going to live longer and you're going to have less health problems. So if you're going to do one thing to improve your health, like move more. And if you're moving not at all, move some. If you're moving, the recommended minimum of 30 minutes most days, like can you push that up to an hour? You're going to get health benefits from moving more, right? So, the hardest thing is getting people to exercise. I have not figured out how to do that in my clinic very well.
You're
So maybe
right,
you guys
yeah.
can teach me how to get people to actually do the exercise. But really, we know that people don't lose a lot of weight from exercise. I'm sure we've all met someone who has, right? But usually they're changing nutrition with it. Where exercise is super important for weight is maintenance. So there's a great database called the National Weight Control Registry. It's all self-reported data that's been going on for decades. People, send in their data of what they did if they have lost 30 pounds or more and kept it off for a year. And that data has a lot of interesting stuff. But the most powerful thing from that data set, and these are people who, didn't use meds or surgery, right? Lifestyle, is 97% of them are moving more than before they lost weight. And 90% of them are moving an hour a day on average. So to maintain weight loss, exercise becomes incredibly important. And that fits with the fact that we talked about when you lose weight, metabolic rate goes down. There's no other way to really increase your metabolic rate other than to move more.
And when you say move more and exercise, are you talking your patients have to do, burpees until they black out, or can you go for a walk in the evening?
So in that data set, most of those people were walking. So walking
Okay.
was the most common form of exercise. Most of the time we talk about
Which is
moderate
also
and
very sustainable.
sustainable, right? Like you can almost always walk. If it's too cold, like it is in Denver, sometimes you can go to, your grocery store or someplace else and walk inside. So absolutely walking and at least a little bit of resistance training.
Sure.
Yeah, it's
Okay.
interesting. I'll speculate because that's what I do, but I'll speculate a little bit about the importance of exercise in that fashion. I can see like it really does kind of create this clustering effect of other habits in the way that I don't know that nutrition alone can. It's easy enough for me to just stick to a diet, but there's other things that aren't necessarily going to be as affected if I slip on that diet. Whereas if I get the bug to exercise and that's something I want to do and I come to genuinely enjoy, I want to eat well because I feel better when I move then. I don't want to go and like get hungover the next day because it affects other things negatively. So I don't know, maybe there's something in that where it is kind of, here you go, Pat, a layup for you, a linchpin of sorts for these other like positive habits that kind of cluster around it. But
Absolutely. And it depends what sort of exercise you're doing, but especially if you're doing exercise with other people. So CrossFit, usually you're doing that as part of a community. So people are like, where are you? Why didn't you come? Where have you been? Right. But even if that's having a walking buddy, a neighbor or a coworker that you walk with, you don't want to let that person down. It becomes part of your lifestyle. You're not going to eat a heavy lunch if you're going on a walk. Like it definitely seems to reinforce those behaviors too.
Yeah, that was my first thought when you said, you had it's hard to get people to buy into the exercise. I was like, dude, find something that you enjoy with people.
Yeah.
That's the huge factor right there.
It's the company that you keep. I mean, if you're sedentary and eating poorly and your friends are sedentary and eating poorly, you're just in that cycle. And as soon as you break out and your other people are eating different and they're moving and their priorities are different, there's a little bit of osmosis, where good behavior is contagious, bad behavior is contagious, and the company that you keep certainly has a large impact on the life that you live.
Or put in lay terms, it's like, man, I don't want to get up and do this thing, but I'll get up and go talk some smack to Pat. And then by extension,
Right.
I end up doing something. It's like, hey, okay, that's a win-win,
Yeah,
right?
Well, 100%. Now here's one of the ones that, again, we are certainly less educated on, and curious to hear your thoughts on, which is medications, because you've got everything from the camp that is probably antiquated and offensive these days, which is, you're not losing weight because you're not trying hard enough and you're just a failure. Then, and the other one that's, medications are the savior of the world, and everything in between. So this is your world. What is it for medications?
I think almost everyone probably starts at that place, right? Where they think, well, these people are just doing it wrong, right?
Mm-hmm.
So, like I've always tried to eat healthy and I've always exercised and I've always maintained a healthy weight. And so you think like, why can't people just do what I'm doing? But people's bodies are definitely different. And once you've gained weight, sometimes that's from a medication, sometimes that's from pregnancy, sometimes that's from stress, trauma. It's really hard to lose it. And we talked about before, right? That metabolic adaptation, that hunger goes up. And so that's where medications come in. So I've been using medications before anyone was using the GLPs. We had other medications before these injectable hormonal medications. They mostly suppressed appetites. They were stimulants, things like phentermine and other medications. But what those did is it let people stick to the plan better. They weren't quite as hungry. So now they could stick to the nutrition plan. And we'd see some results with these older medications. But of course, the new medications, the ones that are GLP-1 receptor agonists, with the first one was something called Saxenda or liraglutide, but it was daily. It wasn't as effective. So even though that's been out for close to 10 years, it wasn't that widely used because it was expensive daily and no better than the pills. So then Wegovy, which people often call Ozempic, came out. But when it's used for weight or cardiovascular disease prevention, it's called Wegovy, same chemical of semaglutide. And then our other really powerful one, which is Zepbound, called Mounjaro when it's used for diabetes, and the generic name is tirzepatide. These really are just game changers because they work for the majority of people. They're about 90% effective of having at least some significant weight loss,
Wow.
which we consider 5%. We consider 5% to be significant weight loss, but about
Okay.
90% of people will have at least 5% weight loss on those meds.
That's incredible. And that I'm assuming medications like that target exactly the couple things that you said.
They help
as
with
why
that hunger.
The hunger you said was the metabolic adaptation and the appetite adaptation. Both?
There's been research on medications to try to help with the metabolic adaptation, which is
Okay.
basically to increase metabolic rate. Those haven't gone well. Any medication that they've had in studies to increase metabolic rate really, it's never made it to public because
Okay.
it hasn't been safe. The stimulants increase your metabolic rate a little bit if you're taking something like phentermine. Now there's metabolic benefits to these hormones in terms of the effect they have hormonally, but they are not changing your metabolic rate. So they are
Okay.
not making you burn more calories. And they've studied that. They're not making you burn more calories. But in the case of Zepbound, the tirzepatide molecule, it looks like it may help you burn fat. So you are a little bit more in a fat burning mode than a fat storage mode. So it makes it easier to break down fat. So it does look like there may be that component. But they mostly predominantly work for weight loss on making people feel more full. And I think you had a guest on this. I checked out before I came on here. So you've talked about this a little bit on the podcast before, I think, but people are able to eat just much smaller amounts of food. They are not hungry as often. So many of my patients describe they could go all day without eating. I don't want them to do that. I want them to eat protein at least 3 or 4 times a day, but they're just not hungry. They're able to finally stick to the nutrition plan that has been suggested to them.
So if we go back, I'm struggling to articulate this a little bit in my head, but just for a little bit of context here. So if we go back to that idea of like, hey, there's one spectrum of people that are like, just suck it up and that you're doing it wrong. And then the other is just medication and don't give it a second thought. I'm somewhere in the middle, I would say, and I'm pretty open-minded about what is going to achieve best result. My skepticism around any sort of pharmaceutical I guess it centers around one, what we talked about earlier, which is, okay, if there's an extreme disruption or metabolic problem, it probably requires a more extreme intervention. I see a lot of people without that kind of extreme problem going straight to that sort of, medical intervention. And then the second thing that I see a lot, and this seems to be more cultural than anything, is that even when I was younger, it seemed like a medical intervention was exactly that. It had a start and an end. And now it seems like a medical intervention is like, well, you're going to take this forever. And something about that just doesn't sit right with me. And that's probably partly my ignorance. I don't know if that's actually the case, particularly with, these types of drugs. But I guess my question is, what makes somebody a good candidate? When is it like this is an appropriate intervention? And then when is it time to say, all right, we've got you over the hump and now we can cycle off? Or is that the case?
Yeah, I think those are all the right questions we should be asking, especially because the way these medications are being distributed right now, people can just go online and get it like shipped to their house, right? Without having much of a conversation with someone like me who can really figure out if it's an appropriate fit.
I didn't know that. I didn't know you could just have it show up at your
dude,
door.
Pat's already got the website pulled up right now.
Yeah, I mean, there's
I didn't know that.
of
Wow.
like telehealth companies that have popped up, and they'll send you sort of like these compounded versions that are like not regulated. It's kind of a scary world out there. So, I think thinking about it medically is helpful, that, you should be considering all the different options. But I'll maybe share like kind of a example patient maybe that might be helpful. So I'm a CrossFitter, although I haven't CrossFitted in a little bit here, but and so I have a CrossFit gym that I go to. I coached at for a while, and so I will get people who come in and they maybe have CrossFit for a long time. They've done all the diets. Maybe they did keto for a while. They've done paleo, and some of them are even like CrossFit coaches or like dietitians, or I treat other obesity physicians, right? They know all of this stuff, but they're still struggling. And again, in Denver, people are health conscious here. Like we don't like drink gallons of sweet tea here. So I'll have people who come in and they describe eating the exact same way I think I eat. They're exercising an hour a day, maybe they're hiking, skiing on the weekends too. They're getting that volume of exercise in, and their body doesn't match what they're doing. And that's stressful enough, right? To be like, I am working so hard to maintain this body fat percentage of 40%. Like, what is going on here? And we know that those people are at risk for things like heart disease and cancer, even if they're doing the right things. So those sort of people come to see me, and it's like, well, maybe this would let you live that life. And so some of these patients, they'll take it and like they're doing their first pull-up that they've ever done because they got 40 pounds off of them, right? Now they can actually do a pull-up. Now they're running. Maybe they were kind of jogging and walking and all the workouts, and now they're actually able to run, and they're running the fastest they've run since they've been middle school. So it really can like change people's lives. But I think the best candidates are people we know this is causing a health problem for, right? Where we see heart disease, in their future. We see diabetes that they have or that they're going to develop. But, the vast majority of people who have a significantly high BMI, like, aren't feeling optimally healthy, right? Like they may have sleep apnea. And the burden of living with a lot of extra weight when you're doing all the right things is really stressful to people. I'll see a lot of women that are sort of like me. They're very successful, like career wise, and they can't seem to figure out the weight, right? And it's really affects their self-esteem. And that can be powerful too, to finally have a body that matches all the work that they've put in.
Do you find, and sadly in 2025, I need to let people know that I'm not attacking anybody or not trying to be offensive. Do you find that sometimes there's just an actual, like a factual and numeric disconnect between perception and reality? Because I've heard of several coaches before who have going to have like a nutritional intervention with their clients, and the coach might say, a conversation, you said, how do you eat? And the report is, hey, pretty darn good. I look at this, the quality's high, the quantity is appropriate. And they're like, wow, it's shocking that you're not having the outcome that you want. Like, hey, I want you to track what you're doing for a week. They're like, I don't need to do that. Trust me, I know what I'm eating. And when they're like, please just do it. And then they come back, they're like, oh, wow, like my week looked a lot different than I thought that it did. Do you find that? Or do you find like even after the tracking, you're like, wow, unless you're lying, this is really confusing. Like you are eating calorically appropriately, the foods are amazing, and you're 45 pounds overweight.
Yeah. I mean, we definitely see both. There's definitely that sometimes that lack of insight, if we're forgetting, that we got a sugary latte or that we were grabbing chocolate every time we walked by our coworkers.
That Starbucks will get you. Yeah. It'll get you.
Yeah. So there's certainly some of that. There's also a fair amount of people, this is like a whole different direction, who have something called binge eating disorder. So they may eat super healthy, but then that restriction will trigger like overeating. So like maybe they're paleo all week, except, when there's birthday cake and they eat the whole thing because they have this loss of control around it. So, there's all sorts of different patterns there, but they're very much are people who I feel confident are eating their 1,200 calories a day and are just not losing weight.
Fascinating. And that sparked a question to me, which is a bit off topic, but it'll probably resonate with some CrossFitters, because CrossFitters can be wonderful yet crazy people at the same time, and especially with some things of nutrition, because I know plenty of people, and I actually lived this way for a while. Maybe I did untold metabolic damage to myself, where they'll be like crazy strict, like weigh and measure crazy strict 6.5 days out of the week, and then I'm gonna, Sunday over from lunch to dinner, it's all bets are off. We're in a free fire zone of nutritional chaos, and you consume about 5,700 calories in a 3-hour period. And
you're just practicing metabolic flexibility, Pat.
Yeah, I was gonna say, yeah. Can you do, even though you ate well 95% of the week, can you undo all of that in a terrible half day of just binge eating?
I think it depends on your body. So, we talked about, everyone's metabolic rate and hunger. The other big thing is insulin sensitivity, which probably you guys are familiar with, right? And so some people are insulin resistance. The vast majority of people who come to see me for help have insulin resistance. Usually it's about 90% of my patients will have insulin resistance. And so those people may be more sensitive to an episode like that, where they truly store that all as fat. So there's going to be some variability there for sure. And I think so you mentioned the people who are like, are they really following the plan? Some are, some aren't. But I remember we did this nutrition challenge at a CrossFit gym I was at a long time ago. And there was this guy, he was like probably 25, 30, real thin guy, and he wanted to bulk up, right? So most people on the nutrition challenge want to lose weight. This guy was like, I want to put on some weight. And he was eating as much as possible. He was doing those like mass gainer shakes that are like 1,000 calories a piece, make me like sick to even think of. And he could not put on a pound, right?
You're speaking Adrian's language right there.
So if you have experienced it on that side, right, where you're like, the math isn't mathing here, right? Like recognize that for some people it works the opposite way, right? Where math, like our bodies do not follow these exact relationships with how many calories we burn and how we gain weight.
Yeah, it is interesting how fixated people still become on that. Well, it's just a math equation, and if you tinker your calories exactly correctly, it'll all work out. The human organism is just so much more complex than that. But anyway, on that, you mentioned insulin sensitivity, and I'm always curious, prior to developing something where that system is really starting to take some damage, like type 2 diabetes or something, how much of that insulin sensitivity can you start to gain back if you start to, change your lifestyle a little bit, et cetera? Because that is always something that is kind of touted in a pseudoscience way with many dietary protocols. It's like, hey, this will affect your insulin sensitivity or start to reset it. Is that actually a thing? And if so, like how much is that possible?
Yeah, the farther you advance, the harder that is to reverse. And that's because you actually start losing those cells in your pancreas, the islet cells that make insulin and make the hormones. That for most people, and again, as we've talked about like a ton, there's tons of variability in what people's bodies do. But for most people, that takes a really long time. So we're
I'm
talking
sorry, the damage or the
damage.
ability
Yeah,
to
the
reset?
damage
Okay.
can be decades, right? So I will often test insulin levels, and they'll be really high in 20-year-olds, right? And people in their 20s who are struggling with weight, right? And they may not get diabetes for like 20 or 30 years, right? So there's a lot of time to solve this problem. Once you already have type 2 diabetes, where you have those really high blood sugars, it's harder to reverse. But we usually quote that it's about 10 years of having type 2 diabetes before it's not really reversible. So if I meet someone and they've had type 2 diabetes for less than a decade, we usually still think that that's fairly reversible and that we could potentially treat their diabetes without a medication, or at least without insulin.
Oh, that's so heartening to hear. Because,
Great news.
Yeah, all you hear from many mainstream physicians is like, oh, type 2 diabetes. I mean, it is what it is, and there's no way that you could possibly control that via any other means, but here's a pill to take, So that is heartening to hear that, hey, it's not a great situation to be in, but like, yes, there's still things within your control that you can start to, navigate with. That's
and
great.
going back to exercise, one of the best things to improve insulin sensitivity is movement. And that for people with type 2 diabetes can be small amounts of movement throughout the day. Just, 10-minute low intensity walks are going to help with that insulin sensitivity. So exercise is the most powerful thing. When I have someone who comes in and they have obesity, and we're looking for insulin resistance to see if they do make too much insulin, if their body's not responding to it. The people who don't have insulin resistance are almost always the people who are exercising frequently. So the people who exercise every day rarely have that insulin resistance. So the exercise is really powerful when it comes to insulin resistance.
Oh, that's very cool. Circling back to a point that Adrian brought up a second ago about, like, hey, are some people going to be on these things forever? I guess, well, are some people going to be on these things forever? And this class of drug, this class of medication, do we know enough as to the pros and cons of actually being on this for a significantly long period of time? Or is it one of those deals where, yeah, it ain't perfect, but it's worse if you're obese for the rest of your life, so the gamble's worth it?
Yeah, that second thing. So I always say whatever you do to lose weight, you should plan to keep doing. So if that's a ketogenic diet, then you're not doing a ketogenic diet for 2 months. You're going to do it forever, right? If you were able to control your diabetes and lose weight, you need to stick with that forever. If it's exercising 3 hours a day, I've had people who do this, right? They get into CrossFit and like jujitsu, and they're like exercising like 3 hours a day, and they're eating healthier, but it's like they really do have enough volume of exercise that's helping. Well, are you going to be able to do that forever, right? To maintain your weight? Same thing with medications. If a medication is what you need to treat your obesity, you're going to need to continue to be on a medication for the majority of people. I think there are some exceptions, but I would expect that 80 to 90% of people, if you need a medicine to lose weight, you're going to need to stay on a medicine. You may change which one you're on based on side effects, affordability, whatever. But if you need medication assistance, you're going to continue to need that.
Do you think have these been around long enough to have like an actual decent pros and cons list? Do we know that?
Yeah. So, and when we talk, there are other medications, but talking about like Wegovy and Zepbound are GLP-1 injectables. So Wegovy works just on GLP-1, and we have had that class of medications for about 20 years now, used for diabetes. We know a fair amount about them. All medications have risks. So there is a risk of, like, say, pancreatitis, which is, severe pain, can damage your pancreas, and rarely can cause death, right? So these are not completely benign. There's really, really, really rare cases of strokes in the eye that appear to be related to it, right? So there are some really rare but scary things that can happen from any medicine, right? I mean, when I prescribe just an antibiotic to someone, some people are going to have an anaphylactic reaction to that. It's not very often, but that's a reason I don't prescribe medications unless the benefit is there. And so when it comes to weight, we really need to think, what's the risk? Well, the risk of heart attack, right? Like the risk of cancers, the risk of diabetes and kidney dysfunction and dementia and all these other things that are related to this. If you just want to lose 10 pounds and your blood work looks great and you are fit and you're hiking up mountains and doing CrossFit and your family history looks great, we're not worried about a lot of stuff, it isn't worth the risk. Like that wouldn't make sense.
Right.
But if we think that your weight is likely to contribute to you having a heart attack at a younger age, to, having kidney damage younger, to increasing your risk of cancer, then there probably is a benefit to taking the medication. I will say my own dad is on one of these medications. It's changed his life. And I feel confident that he's added a decade of life to his life because of them. So I would say, if you have health risk factors, then the benefit may be there for you.
It's just a decision matrix. You've got to, you've got to make the choice. Okay, fascinating. I'm sorry, Boz, I cut you off. Go ahead, man.
No, I was just curious about the comment about, okay, whatever the intervention is, you should be prepared to do it for the long haul. With regards to medication, I wonder if people that were quick to dabble with these, we mentioned how easy they are to get these days and that sort of thing. If that was the thinking going in, I wonder if that would just change people's approach or at least consider something else at the start.
Yeah. And I think it's always reasonable to try something else first, right? If you have
Right.
never tried a supervised nutrition plan with coaching, and you haven't tried, getting any coaching on exercise or support there, start there. There's for most people, unless you already have type 2 diabetes or you're really sick, you should start with lifestyle. Try it.
Yeah.
Some people will be successful. But if you are like many of my patients who have tried that for 20 years, like maybe it's time to
Yeah.
do something else. But if you've
Well,
never done it, do something else. Try and
Sorry, Pat, I got
go ahead.
one more on that. I completely agree. I think that, hey, starting with something a little bit less permanent might be great. And we have talked about some of the benefits that seem to be associated with these. What are some of the drawbacks? Because that doesn't seem to be talked about.
Yeah, I mean, there are,
so
again,
many
some rare risks, right? So pancreatitis, which is an inflammation of your pancreas, which usually lands you in the hospital. And again, very rarely could lead to death. Like we're talking like maybe 1 in a million, right? Like very rare, is a possible side effect. Gallstones, anytime you lose weight, you can get gallstones, especially for middle-aged women. We're at more risk. So that's a possibility. So you could need surgery for that. The meds may increase the risk of that. And then again, these really rare eye strokes, again, like more than 1 in a million, right? Super rare, but there, and a reason not to maybe dabble with these medications. So those are sort of the biggest scary ones. Listed on it is also a risk for thyroid cancer. This is because these medications do appear to increase the risk of thyroid cancer in rats. We do not think that this translates to humans because humans don't have the receptors on their thyroid for GLP-1. But, and again, these meds have been out for like 20 years now. So we really don't think that's a risk in the real world, but a reason not to dabble, not to take these if there's a better solution or if there's not a pressing health reason that these could help you. And then the more common side effects, because these work on gut hormones and they make you feel more full, nausea, especially if you eat too much or you eat heavy foods, right? So foods that would just the way my body is made make me sick to begin with are probably going to make someone sick on these medications, right? If you have a big greasy cheeseburger and french fries and you eat too much of it, you're going to feel overly full or sick. Some people will get constipation or diarrhea. Those usually we can work through, as a doctor, like I treat those things. We have tools, we can use fiber, we can usually work through. And sometimes just switching from one medicine like Wegovy to Zepbound or Zepbound to Wegovy will solve those common side effects. So overall, very few people dropped out of the drug trials due to side effects. So we hear these really sensationalized things in the news. The majority of people in the trials and what I've seen clinically are able to tolerate the medications. So, especially if you're eating the right way with the medicine. If you just take the medicine and go eat, 4 pieces of pizza, you're going to feel sick.
Interesting. That's fascinating. So kind of it encourages some good behavior through some interesting process. If we circle back to the actual beginning of this show, I identified that there was 5 components that you use in treating obesity. We made it through 4. We just chatted on the medication one for a while. The last one seems so simple, right? But I'm sure it's rather challenging, and that's behavior change. So what's that all about?
That can be so many different things from, like you mentioned, logging food, right? That accountability, that knowledge, logging exercise. How many steps did you really get this week? How much movement did you really get? So the logging component, changing mindset. A lot of my patients were raised in what I call the clean plate club, right? Always finish your plate. And so we'll have to work through that and talk about it's just as wasteful to put it in your body if you don't need it as to throw it away. Now your body has become a garbage can, right? Some of those mindset things, changing your relationship with food. Is there another way to de-stress or to find comfort when you're sad that's not food? So working through some of the emotional eating that will happen, working through social situations. What are you going to do at a birthday party? What are you going to do when you're at a restaurant? Alcohol, I see this a lot. Like, how are you going to cut back on that? That may be a big part of people's social circle. So all those sort of like lifestyle changes that go along with this that let you be successful. And some of them are really big mindset things to overcome, right? The emotional eating is big for a lot of people.
Sure. Yeah, I was going to say, do you have anything that you have found to be successful with changing people's relationship with food? Because I know a ton of people that struggle with that, and any insight would be appreciated.
And I will say that's like one of the powerful things with the medication is for a lot of people, it gets rid of this food chatter. Like they just don't even think about it anymore. So they will say, oh, normally if I'm stressed, I'll go eat cookies. And like that just doesn't even occur to them on these
Oh,
medications.
wow.
Yeah.
That's huge.
It's insane, honestly. Like what I've seen clinically is just, it changes people's lives. And now they're like, well, now I need to do something else with myself. And so they do go join a gym or they take up a new hobby or something because their brain's first instinct isn't like, go eat.
And I can see how, if that's the case, that you may have to be on this thing long term, right? Because if suddenly you stop and boom, that chatter comes back as intense as it used to, well, of course, you're going to go right back to what you're doing previously. Like, of course, that's a wonderful benefit, but it does also kind of hook you in there that.
It definitely, yes, people get really distressed often stopping it because now that food chatter's back. And then they saw what their life looked like if they were able to eat healthy. And a lot of times people do start exercising. Sometimes it takes like 6 to 9 months of being on the medicine. But people who, like, I just saw someone earlier this week and she's, someone who has a lot of medical problems related to her weight. She's on oxygen, and she's been on these meds now for a little bit. She's lost some weight and she just got like one of those trampolines and she's like doing 10 minutes a day on the trampoline. And it's like, this is someone who I don't think would have ever started exercising without being on these medications. So people's lives do really, really transform on these in terms of their ability to exercise, their ability to eat healthy, and that brain chatter around food just often melts away.
Is there no kind of reprogramming or new habits that are built with time on this medication that are preserved if one cycles off them?
Yeah, I think, for example, like exercise, once you have gotten in that habit, you may very likely continue that, right? And so that would be a very helpful thing to maintain weight off of the medication. But I think and so that was like the old thinking with medications is like, we'll give you the medicine, you'll learn the habits, and then we'll take the medicine away. That was like the thought, in decades past. The problem is that there's just physiology that's beyond our control in terms of that hunger. And so you may now have the habit of eating a protein shake for breakfast and having a salad with chicken for lunch and having your Instant Pot meal that you made for dinner, right? But you're hungry in between. And so now you're eating all the snacks that you didn't when you were on the medication. And so I think that thinking is what medicine did for decades prior, but the reality is people are just, your body is really trying to regain that weight. You're just actually hungry. And so even people with the best habits in the world can struggle. And That's what's been powerful in my practice, because I do see physician colleagues, I see CrossFitters, I see CrossFit coaches. They know this stuff. They have discipline. They're people who have done amazing things in their life, but they still struggle with their weight.
Have you, and maybe you don't have to deal with it, well, you can tell me, because I'm going to assume that if people are coming to you, they've made a decision to come to you and they're aware that they have an issue. But, so maybe they're open to that discussion. But it seems to me that these days it's almost taboo to bring up somebody's weight. And I'm curious to give people any tips or tools, because if you have a husband, a wife, a friend, a mother, a father that's significantly overweight, well, if you love this person, you want them to be around for as long as possible. You want them to have the highest quality of life possible. You want to mitigate their risk for chronic disease as much as possible. And if you know that they're in this camp of a profoundly elevated risk factor because of their weight, I almost feel like, how could you not address it? Like, I care about you, I want you to be around, but then it's like, well, how dare you? You're not allowed to touch that topic with a 10-foot pole. Any guidance to somebody who has a loved one who falls into this category and they want to broach the subject, but they just don't know how?
I think the closer you are to someone, the harder it is, because it feels like you're picking on them, right? Or you're judging them when it's someone really close to you, a spouse or a parent. Those are the hardest people. When I talk to, and you're right, at this point, people come to me asking for this help, but it wasn't always that way when I was, practicing more just family medicine. And the way I found was the best to bring up the conversation, and this may work more if you have like an athlete in your gym or something that you want to broach this with, is simply asking, what do you think of your weight? Like, what do you think about your weight, right? That lets them lead the discussion, because there is a lot of body positivity right now, right? Which I think is great in many ways. And so some people may be like, I'm happy with it. Like, I feel great. I never, ever, ever had anyone give me that response. Everyone, at least in the area of the country I'm in, were like, oh yeah, doc, like, I know I need to lose some weight. Do you have anything that can help me? And so I think many people feel hopeless. They may have tried or think they tried at least things in the past. And so they are not asking for help because they either have so much judgment against themselves that they think they can do this on their own, or they don't know that there's better tools that they qualify for. And so, I think if you can just ask that simple question of like, what do you think about your weight? Just like very not judgmental, right? And it lets them drive you like, oh, I'm so frustrated. I tried keto again and it didn't work. Or like, I just feel hopeless. I'm so sick and tired. I can't even work out. Like, I know you work out, Pat. I just can't do what you do because my knees hurt, right? Like, people will say stuff like that. And so then you've opened the conversation and you can direct them to the person who maybe can help them.
Do you find that the medical system these days is set up in a way that it makes it difficult for doctors to address this? And why I ask that is, when this topic has come up before, I've heard people who are in medicine, be it physicians, nurses, somewhere in the system, say that the medical organization has changed over the years. And while sure, these people who are coming into your clinic or hospital are patients, it's almost more like they're customers now. Like, they're going to fill out a survey and your bonus is going to be linked to how happy you made them feel in this survey. Like, there's an incentive structure which is potentially perverse. And if you tell people bad news that makes them sad, which is, you're unhealthy, you got to lose some weight, you're going to die, and we got to get in there now, they're like, where's that form? Like, it doesn't go that way. That it's sometimes the incentive structure of patients versus customers makes some physicians hesitant to bring up things which might negatively affect that incentive structure. Am I wildly off base? Is it related to that?
And so I'm an independent physician. I own my own practice. And so I am not tethered, to those sorts of things. My patients are still customers. If I was a jerk and they didn't like me, I guess I'd go out of business quickly.
Bedside manner is still a thing. Yeah.
Right. Like, I want to make them happy. I want them to like me and leave feeling like they got better and had a good experience. But I don't have anyone else, judging that. So if I have a patient who does get mad and like leaves me a terrible review, like, I'm not losing my job because I'm my own boss. So I think there is some of that. There's also, in corporate healthcare, there's not much time to spend with patients. So, you may have wonderful doctors, but if they have 15 minutes to take care of everything going on with someone.
Right.
I mean, when I see someone for the first appointment about weight, I spend 60 minutes with them and I usually go over. They're telling me so many of their experiences, everything they've tried, how their parents made them, clean their plate, their childhood trauma, the things that didn't work, how frustrating it is, like all their aches and pains, to really just get to know this person and get a handle on what is going to work for them and establish that patient rapport so they trust that I have things that are going to work for them. That takes me a really long time. And so, if you're a physician and it's just more of a job and your job is to see people in 15 minutes, you can't have these in-depth conversations.
Yeah, that makes perfect sense. And I have one more question that is because I totally don't know because I'm outside. And so I just hear the rumors. I don't know if the rumors are just idiotic or true. Is there an incentive structure? And you've got a specific practice for obesity, but like let's say in the big hospital, right here in the big hospital, that these piranha come in, right? The drug reps come in and they're trying to, get doctors to use their drug compared to somebody else's drug. And, what's the incentive structure? Or is there an incentive structure linked to some of these medications that might influence whether they are underprescribed, overprescribed, or anything in the middle? I'm totally naive to that.
There is no incentive instruction structure. So I actually am a speaker for one of these drugs. So I do get paid by Zepbound to go teach other doctors about these medications. So if you look me up, you can look up any doctor and find out how much money they're getting from drug companies. So you'll see that Eli Lilly does give me money. Eli Lilly gives me money to go teach other doctors about these medications and advise them on other things on the medication. I get no money, nor does any doctor anywhere in the US for what they prescribe, right? So there is no kickbacks. Those are 100% illegal. I maybe in the 70s, I don't know, way before I was born, maybe that was a thing. But we do not get any incentive. At best, you may get like a free lunch once a year from the drug company because they want your time to like show you something new.
Gotcha.
Like I can buy my own lunch. I can buy my own coffee. So, there is no kickback. So I don't know where these rumors come from, but I appreciate you asking that because there is no incentive that your doctor is getting. And in fact, in the case of these medications, they are a giant pain in the butt to prescribe. So I usually have to fight so hard to get them for my patients. I have virtual assistants who help me do what we call prior authorizations. When there's been shortages, we have to call around and find a pharmacy that has them. So it's a significant investment of my time that's completely uncompensated to help my patients get these medications right now. So yeah, there are no kickbacks. Your doctor doesn't care if you take a medicine or not. It does not affect how much money they make.
Well, that's absolutely wonderful. That's the best response I could have hoped for. And I guess you talking about compensations, the kickbacks, and incentives and whatnot triggered me to think is there anything going on right now with this class of medication, which is I'm thinking more and more people are going to be taking every year and benefiting from, and they could be on it potentially forever. Is most of it easily covered by insurance, or does that vary wildly?
That's a whole other podcast episode. That's a passion of mine. But no, as of right now, coverage is pretty spotty. So I don't know when you're going to be releasing this episode, but Medicare is often what sets the tone for things. So Medicare has all these federal policies, and most of the time private or commercial insurance, if you had United or Blue Cross, they kind of follow what Medicare does in a lot of ways. So Medicare has expressly prohibited covering, quote, weight loss medications for a couple decades. They refuse to cover these. Now, the Biden administration suggested, in November or something that Medicare treat this as obesity, not as weight loss, and that they should be covered for patients on Medicare and Medicaid. How that is all going to play out is going to happen sometime in the end of January. And so we'll see. It would be life-changing for people if Medicare and Medicaid covered these medications, because right now, those patients that have Medicare and Medicaid, they either have to pay cash for these meds or they just can't get them. So there's a huge chunk of our country that has no access. And then even with private insurance, because there's still so much stigma around obesity, even though it's been accepted as a disease for more than a decade, insurance companies often carve out treating obesity. And so a lot of insurance plans will not cover even talking to me about your weight, let alone the medication. So there's a huge access gap. And that's why a lot of people are turning to these sort of unregulated generic compounds of these
Gotcha.
medications, because
Ah,
sometimes that can be cheaper. But then there's a ton of secondary gain there because the people who are selling those compounds are definitely making money off of them. So there's a lot more
fascinating.
secondary gain in the compound space than there is in the traditional medical prescribing space.
Interesting. Okay, that's very good to know. I did not know that. Yeah, Boz, anything more from you, man?
No, I think all the questions that came up, we had a chance to talk through. So yeah, I really appreciate the time.
Well, thanks. It was a blast. And I hope that just, people, anyone listening, if you have struggled with your weight, you realize you may be doing all the right things and it really is not your fault if you're struggling, and that there is different solutions out there that may help you be more successful.
Doc, in closing, can you let people know if they want to follow you, link up with you, connect with you, see what you got going? How can they do that?
Yeah, so it's Dr. Francavilla, Francav as in Victor, ILLA. And if you go to my Dr. Francavilla website, it will take you all my different places for healthcare providers. I have a website called helpyourpatientsloseweight.com. And then my podcast is just the Dr. Francavilla Show. And I have a weekly podcast that's everything health and weight related.
Very, very cool. Doc, genuinely appreciate your time. This was a very interesting, educational, and informative show. So I think everyone's going to really get a lot from it.
Thanks for having me.
All right, for the good doctor and Adrian, I'm Pat Sherwood. Thanks everybody for watching, and we will see you next time.